creative with the names they came up with. So, yeah. So, okay, so let's get started. So we have a 45-year-old male. He comes to the emergency department at 1 o'clock in the morning with substernal chest pain, and the history that we got from the EMTs was that he was at a party dancing and he felt a sudden crushing pain across his chest. And at that time, he was saying it was the most severe pain he's ever had in his life. And he was complaining of neck pain as well at that time. The pain has been constant. It improved mildly when he got medications from his friend. And we find out later that the medication he used was Percocet. So when he comes to the ER, he looks inebriated, so he looks drunk, but he also looks anxious and he looks like he's in significant distress. It's hard to get a history from him, but his girlfriend is there and is able to help out. So, Dr. Faris Khan, is there anything specifically that you'd want to know about the patient's history?
Can you hear me?
Yeah, I can hear you.
Okay. I think one thing that would be helpful to know would be the family history, because I didn't see anything about family history in here.
Yeah. So why is the family history important?
There could be like some genetic disease that could contribute to his condition.
Okay. So like which one?
I can't think of anything from the top of my head, but sorry, I can't think of anything from the top of my head.
It's okay.
Yeah.
But that's a really good thought, because something like hypertrophic cardiomyopathy, where you have that middle part of the heart, the septum between the right and left side, can become thick, where that tract leads out to the aorta. So if it becomes too thick, you obstruct the aorta and you can't get any blood flow out. And so those are the young athletes that drop dead as they're playing, because you're completely occluding that aorta and you can't get any blood out. But that's a really good point. The one thing I would say is, with family history, if we're talking about chest pain, it's more to see if like the dad or a grandfather or somebody else in the family had a heart attack at an early age. But family history is very important. And so he doesn't have any family history of early heart attacks. Okay, but good. Anything else that you'd want to know about in the history about what's of his presenting symptoms of the chest pain?
So the history has already been given, right?
Not all of it.
Not all of it. Okay.
So we can go through. Let's go through kind of like that mnemonic that we use, the OPQRST one. So we say that the onset was about. I don't think I have it here, but I think I remember putting like it was at 1 o'clock, so it happened maybe a few hours before that. It was sudden. That it got a little bit better with Percocet. Which what kind of medication is Percocet?
I think Percocet is some kind of like pain reliever.
It's a pain reliever. Do you know the type of medication it is though?
I think I searched it up before this. I think it's an opioid.
Yeah, it's an opioid. Good. So it's like morphine. So it's an opiate pain reliever. Good. And it doesn't look like anything else is helping his pain. The pain has been constant. It's a crushing type pain. And he says the worst pain he's ever had in his life. So that kind of, we have that history of what the chest pain is like. So good. So let's go with Dr. Rashid. So the patient was seen, so the girlfriend is telling us the patient was seen with an old friend from law school, and he had more to drink than he usually does. And there were a few times that he went to the bathroom, and the patient started to get more wild as the night went on, and started jumping on tables and dancing. So, anything in that history stick out to you?
Hi, can you hear me?
Yep.
Okay, so maybe if he was like going, maybe if he like fell out of if he fell maybe.
Yeah, so if he fell, exactly. So so in the next sentence, actually, I say that he was up on the table, he fell down onto the floor and hit his left side, and at that time he was complaining of, that's when he started complaining of the chest pain. So that's a very good point. Why are you worried about if he fell or not?
Could it cause like a brain injury, like internal bleeding?
Good. So yeah, it can definitely cause a brain injury. But what else? He's complaining of chest pain.
Anemia thorax, maybe?
A pneumothorax. Perfect.
Yeah.
So you have a collapse of the lung because of some injury, and he hit that left side, and that's part of where he's having pain. He's saying it's hurting all throughout, but he's having pain in that area too. So good. So what would you want? So if let's kind of skip ahead. If you wanted to rule out a pneumothorax, what would you do?
A physical exam to check for any swelling or any trauma injury.
Yeah, so a physical exam will tell us. We would typically hear, if it's on the left side, we wouldn't really hear good lung sound on the left side. We can't hear the breath as much. And as we tap on the back itself, it'll sound very hollow. So those are signs of a pneumothorax. So Dr. Medina, what else do you want to get?
Chest x-ray. So you would be able to see if like the lung is collapsed, or if there's if it looks a little deflated.
Good. So chest x-ray is definitely the quickest thing that we can do to do that. And so we order a chest x-ray, it's pending. So we'll get to that later. But let's say he's coming in and his neck veins are distended, he's having a hard time breathing, and he looks like he's in a lot of pain, and he looks in distress. What is something that you're going to be worried about in that presentation?
Okay, so that's normally like jugular vein distension, so that would mean that it has like completely collapsed, maybe, or
potentially. But let's say you also see his trachea deviating to the opposite side, to the right side. What would you be worried about?
Tension pneumothorax.
A tension pneumothorax, perfect. And what do we do for a tension pneumothorax?
You would have to release the pressure. Needle decompression.
Perfect. And so you stick a needle in there, it relieves that pressure, because with the tension pneumo, you have basically air being pushed into the thoracic cavity, but you can't get that air out. And so when that happens, you're basically deviating everything to the other side because you're building up pressure. And as you deviate everything to the opposite side, the vessels feeding the heart are going to be compressed pretty much, and you can't get blood into the heart. So if you can't get blood into the heart, you can't get blood out of the heart, and so your whole circulatory system collapses. So good job. Good. All right. So let's go with Dr. Naya. So we had mentioned that that he was drinking more than usual. He went to the bathroom. He's getting more wild. Started jumping on tables and starting to dance. Why is it important that I gave you that history?
Hi, can you hear me?
I can hear you, yeah.
Okay, so the fact that he was like acting all wild again, like looking for trauma, but also the fact that he was drinking more than usual,
Mm-hmm.
plus mixing mixing of his drugs. So like his Viagra, I looked it up. It usually has negative effects when mixed with alcohol. So we'd want to know like maybe the last time he took it
Okay, so
before
yes,
he started drinking.
that's a good question to ask. We'll definitely come to that in a bit. And I think someone on YouTube is kind of mirroring what you're saying. So one thing that stood out to me was his ED. He's taking sildenafil in order to treat it, possible side effects of an MI. Yeah, so we'll definitely get to that. So, but we know he's taking alcohol. He's drinking alcohol. What else? What else would you want to know?
I can only think of doing a physical, so like again seeing what kind of trauma or
Okay.
if he suffered any trauma.
That's a good thought, and we would definitely do that because we don't want to miss potential trauma. Dr. Haddad, what else do you want to ask?
Because in his history it says that he's a meth and cocaine user. I want to ask if he was using those at the party.
Exactly, and so if he's out there sneaking off with his friend and he is coming back all wild and rowdy, then yeah, you should definitely be asking about drug use. And so it's good to note that he has a history of cocaine and meth use. What would you be more worried about in this instance?
Because he was like dancing on tables and cocaine is a stimulant, it would suggest that he was using cocaine more than the alcohol.
Yeah, so potentially, it all depends on the dose that you take in. Meth is also a stimulant, so he could also be using meth, but a lot of times it's harder to, well, I guess it depends on the party, but it's harder to use meth than it would cocaine. So good. All right. So he vomited a total of 3 times. Vomiting didn't improve his pain, and he did not hit his head. So, Dr. Hafsa, why is it important that I tell you that history?
Based on the meds that he's taking for the ED, it can cause an upset stomach and headache.
Okay.
So that could be the reason why.
Okay, good. But he is having, he fell. So what are you worried about if he fell?
That his trauma is more than what we think it is.
Yep, potentially. So he's coming in altered. He looks drunk, but he's not himself. So is there anything else that you'd worry about in this patient?
I'm not really sure.
Okay. Dr. Abid, what would you worry about?
Since he fell, and the vomiting, keeps on going, maybe we could see if he suffered from a concussion.
Yeah, so he can have a concussion. What else is more dangerous than a concussion?
If we're talking about like head trauma or stuff like that, we can check for a stroke.
Stroke. Stroke wouldn't necessarily be caused by head trauma. What else?
I'm not sure.
Okay. Dr. Sandhu, what are you worried about? If he's altered and he had a fall, what would you be worried about?
So like internal bleeding, like I said hemorrhage possibly.
Okay, hemorrhage where?
It could be epidural, subdural, like either one, I guess.
Yeah, so I mean in the brain, right? So in that cranial cavity. So where the brain sits, it's an enclosed space surrounded by your skull. So there's nowhere for any of that volume to go. So if you're bleeding into that area, you're going to basically compress the brain. You can have something like a stroke from it, or more likely, if you're bleeding in rapidly to that area, you're going to, there's nowhere for that brain to go. So you're just going to push it down. And so you can herniate the brain and you can die from that. And so if anybody has a fall, they're coming in altered, you need to make sure that they don't have a brain bleed. So any type of imaging that you would want to get for that?
So probably like an MRI.
An MRI. MRIs take a long time. What if this patient has a brain bleed and dies? What would you want to get instead of an MRI?
CT.
CT, yeah. So non-contrast CT you can get very rapidly, and you can tell pretty quickly if that person has a brain bleed. So yeah, good job. So somebody asked, but he didn't hit his head from YouTube. Yeah, he didn't hit his head, so our suspicion is less likely. But we're getting the history from the girlfriend, so we don't exactly know if that's 100% accurate. So you always want to keep that in the back of your mind where your history comes from. Okay, good. All right, so he admits to nausea, vomiting, which we already know about, palpitations, and worsening headache. With the fall and somebody that has a worsening headache, we want to make sure that there is not a brain bleed because blood in the brain it's an irritant. Just like blood anywhere else can be an irritant, it's going to be an irritant in the brain. And so having a headache is one of the signs of having a brain bleed. That's that thunderclap, worst headache of your life. If anybody tells you that, you should always worry about a brain bleed. All right. So some history. So he's allergic to lisinopril, which is not really that important. He's taking losartan and lisinopril. So Dr. Vivian, why is that important to know? Let's go with Dr. Langsing.
Hi, can you hear me?
Mm-hmm.
It's important to know the combination of his blood pressure and erectile dysfunction medications to see like what they would do to the heart pressure and like the blood stroke volume.
Good. So with the losartan, that's a blood pressure medication. It's going to be important to know if he's taking his medications or not. But let's say he is. The losartan's not necessarily going to give you chest pain. Neither would the sildenafil. But why is the sildenafil important to know about?
I'm
What's
not
the
exactly
sildenafil?
sure. It's for erectile dysfunction.
Okay, so how does it work?
It's sending more blood to the male genital area.
Yeah, so it's basically getting more blood to the penis so that it can actually become erect and stay erect. Now, if that's basically vasodilation, so we're bringing blood to that area. He is 45 and he has erectile dysfunction. Is that normal or is that a little young to have ED?
I would think it's a little young.
Yeah, it's pretty young to have erectile dysfunction, and so that tells us that he has some narrowing there in the penis, which also means that he probably has narrowing other places in his body. One of those places can be where?
His heart?
His heart, exactly. So he's coming in with chest pain. He has erectile dysfunction. He's pretty young, so he might have stenosis other places like his heart. So that increases our suspicion for something like
A heart attack?
a heart attack. Perfect. Good. Dr. Nikita, what else do we want to know about the sildenafil?
Can you hear me?
Yep, I can.
I think you would also want to know like the side effects and what it might possibly like react with, I guess. I think
Yeah. I mean, that's good to know. He would tell you that it's working really well. He has no complaints. So what else do you want to know?
Like maybe his dosage or like how often he takes it.
Yep, that's good to know. Dr. Mina is helping you out. What else would you want to know?
Oh, I see. Last oral intake.
Yeah, so when was the last time he took it? Why is that important?
I'm not really sure. Maybe like how much of it is like in his body. How like I don't know.
Yeah. So okay. So Dr. Mina, help her out. Why is that important?
Because you want to know if like if you can administer nitroglycerin.
Okay, and why would that be a problem?
Because it's also a vasodilator, so it can lead to hypotension.
Okay, so you have the sildenafil, which dilates your vessels, and then you have nitroglycerin, which dilates your vessels. If both of those work together and they're both on board, you can have a significant drop in your blood pressure. And so nitroglycerin is typically used for chest pain, for angina, and so it'll help dilate the coronary arteries, but it can dilate other places too. So good, good. So we'll stick with you. He lives by himself. He drinks about 2 or 3 drinks a day after work to help him sleep. He occasionally uses cocaine. He occasionally uses methamphetamine. So what's important about that history?
You want to know, like the side effects.
Yeah. So what are the side effects of each of those medications? What else would you want to know?
Well, he's also he lives alone. I believe it said. So you want to know like his social history.
Yeah. So if he lives alone, if he's depressed, if he has other issues going on, one thing is that he's taking 2 to 3 drinks a night. Is that, and I think his drink of choice is whiskey. Is that normal?
No.
No, right? It's a little bit too much. So if a lot of times if patients tell you they drink 2 to 3 drinks or something along those lines, you always want to trust patients and believe them, but you also should have a suspicion in the back of your mind that they might be telling you less than what they actually take. And so that's important to keep that in mind. And if he's taking these medications, or he's using alcohol, he admits to cocaine and methamphetamine, he might be using other drugs as well. So those are all things that are important to keep in mind. Most likely this history was taken from his girlfriend, so we don't even know if that's 100% accurate. So Lulu's asking, can we screen for depression? You can, probably not in him right now because he's inebriated, but you can and you should. It'll help his long-term recovery. So Marina's asking, cocaine is a stimulant, alcohol is a depressant. Will they have any effect? They will. It depends on the dosage of which substance you use. If you drank way more alcohol and you did a little bit of cocaine, you're going to have more of the depressive effect versus the other way around. You can be more stimulated. So good. All right. And so his blood pressure. So let's go through the physical exam. So let's go with the vitals first. So let's go with Dr. Verena. His blood pressure is 185 over 108. His heart rate is 121. His respiratory rate is 20. His temperature is 98.4, and his O2 sat is 97% on room air. What stands out to you in that?
So the first thing that stood out was the blood pressure that was really high, and then the heart rate is sort of high. So that leads me to think that there's probably something like cardiac happening. So in terms of labs, we would probably need to run and check for troponin.
Okay, yeah. So that's good. So we know that he has a elevated blood pressure, and that you're right, that is actually very high blood pressure, and his heart rate is pretty elevated too. Is there any specific cardiac issues that you'd be worried about, or causes of chest pain that you'd be worried about with those vitals? Let's take the tachycardia first. Anything specifically that you'd be worried about?
So one thing I noticed we didn't really discuss was his diet. So that may have an effect on any possible an angina or something.
Okay.
But yeah.
Okay. So angina can cause tachycardia if he is in a lot of pain. What else? Dr. Mina saying a pneumothorax, which is definitely true. Let's say he had isolated tachycardia and some shortness of breath. What would you be worried about?
We originally were talking with my group about a pneumothorax, but since we don't know if he fell, that was sort of ruled out. But then we were worried about a MI because of the pain symptoms and stuff.
Good.
That's the one we were focusing on.
Good. Good. So Dr. Sudakar, I apologize if I mispronounced it. You're saying pulmonary embolism. So why is that?
Can you hear me?
Yeah.
Okay. Well, usually with the pulmonary embolism, you will have tachycardia, and I think that's one of Roll's criteria. But the reason why I'm a little hesitant on that is there aren't tachycardia and shortness of breath are both symptoms for pulmonary embolism.
Okay.
But he's not showing any other symptoms of pulmonary embolism, which is why I'm a little hesitant on listing that.
So what is it that he's not showing that it would make you think it's not a pulmonary embolism?
I guess one of the things would be he's not showing signs of swelling or so DVT. He's not showing any signs of DVT. I think that was the main thing that I would look for to confirm pulmonary embolism.
That's good. So having a DVT or signs of a DVT will increase your risk of having a pulmonary embolism, but it doesn't rule it out. But you, like you said, you have to look at the whole picture. He's not really complaining of shortness of breath. He's complaining of chest pain. He's not. He's tachycardic, yes, but his oxygen saturation, is that normal or is that low? Is that high? What do you think? It's 97 on room air.
Isn't that pretty normal?
Yeah, it's pretty normal. So with the PE, are you going to have a normal O2 sat?
No, you would have decreased O2 stats.
Yeah. So yes, generally. So I've seen a few PEs that they were small and they had a relatively normal oxygen saturation, but yeah, you're right. It'll usually be low. Okay. So he doesn't really have those other symptoms. So, but good. It's always good to keep that in the back of your mind. All right. So we know he has a pretty high blood pressure and he has tachycardia. So Dr. Kazi, what on the physical exam do you want to know about?
Well, could you repeat it?
So what about the physical exam do you want to know? What's the first thing you'd want to check?
Check for sounds.
Sounds where?
The heart.
Yeah, so heart sounds. He is tachycardic, but there's no murmurs, rubs, or gallops. His dorsalis pedis and radial pulses are intact, and his cap refill is less than 2 seconds. So really, everything's normal except his heart is going fast. What does the dorsalis pedis and radial pulses tell us? Is that really significant in this case?
I'm a little unsure.
All right, it's okay. Dr. Mina, what are you? You're saying adequate perfusion. What do you mean?
That he's getting blood throughout his body and his organs. So
okay. Okay, so what would we be worried about if that wasn't the case?
An aortic dissection, or
why would that? Yeah, why would that cause? So yeah, I would be worried about a dissection, but why?
because I'm not sure, but maybe because one of his like extremities might not be getting. I'm not really sure.
That's okay. So it's a harder question for sure. So as the blood leaves the heart into the aorta, so the aorta arches like this as it goes down to the back and perfuses the rest of your body. But as it arches up, you have 3 branches going out. 2 of those branches are going to be going to your left and right arms. So if you dissect and you affect one branch but not the other, the pulses on that side are going to be affected versus the pulses on the other side won't be. And so if you have that pulse difference, you would be more suspicious for something like a aortic dissection. But good. Good.
What about an aneurysm?
An aneurysm. So an aneurysm is basically like an outpouching of a portion of that vessel. So an aneurysm wouldn't necessarily cause a difference in pulses. So a lot of times we think of when we think of aneurysms, we think of it lower down in the belly, and abdominal aortic aneurysms wouldn't necessarily cause that different impulses. Even if the aneurysm was higher up, it typically wouldn't disrupt the blood flow out to those arteries supplying the limbs.
Okay.
But that's a good point too. Especially if he drinks and he uses cocaine and meth, we don't know if he smokes, and smoking is a risk factor of MI, but also of developing an aneurysm. Though he's kind of young, so. But yeah, good point. All right, so. Is there somebody really named Money Meat for Life here?
I think that's like my username. I thought when you called on me, that was me earlier because my last name is Sandhu. So I thought that was me.
No, that was you. It's just on my list. It's written as that. I'm sorry.
Yeah, that's like my old email. I don't know why that came up on as my name. Like I was confused when I saw it on Google Sheets.
It's okay. Sorry about that. I didn't mean to call you out.
No.
Okay. So, all right. Let's go with Dr. Ethan. Anything else in the physical exam you wanna focus in on?
Hi. Can you hear me?
Yeah, I can hear you.
Okay. What else in the physical exam? I want to know if he like leans forward, does that do anything for him? Like I want to know if he breathes more, does it hurt? Because I don't know if it wasn't in history that if the more he breathes, the more it hurts. So
yeah, so he didn't have that. But talking about breathing, what about his respiratory exam is important because of what? What would we want to rule out with the respiratory exam? We kind of talked about it a little bit earlier.
Oh, okay. The pneumothorax. You want to see if there's like if there's hyperresonance in the side that he fell on.
Yeah, exactly. And then also like something with a pneumonia, you can hear some crackles, stuff like that. So yeah, good job. And then for the rest of the exam, because of time, it's more or less okay. The one thing that I usually will do when I first hear about a case and we're kind of going through this is getting their general exam. How do they look in general is very important because it helps us triage between somebody who's really sick and somebody who's not sick. And when we go through abdominal pain, that's going to be really important to note. So for him, he looks well developed, well nourished, but he's in significant distress and he's diaphoretic, so he's sweating like crazy. And so he looks like he is sick. And he has some slurring of speech, which is important to note because he fell. And so if he has slurring of speech and he fell down, he hit his head, like we talked about before, it can be a brain bleed. Most likely it's going to be from the alcohol. But Dr. Ethan, if we want to tell if it's alcohol or potentially a stroke or a hemorrhage, what would we do?
To differentiate between
like a physical exam thing that we can do.
I don't know the name for this, but like a neurological exam. There you go.
Yeah, exactly, a neuro exam. So you do a neuro exam. to check to see if they're moving their limbs equally, if there's any deficits. And for him, it was symmetric. He wasn't really following directions because you can't do a full-on neuro exam. But yeah, so if he's able to move his limbs symmetrically, they're both moving. It's probably not a stroke. But if one he's able to move up and down, the other one you bring it up and then you let it go and it just drops and you can't move it, then it might be a stroke. So yeah, good job. You look for symmetry. Look for the differences on both sides. Good job. All right, so let's go with Dr. Lepak. What labs do you want to know about? All right, let's go with Dr. Lulu. What labs do you want to know about?
We're probably looking for cardiac function, so maybe a troponin, and probably a tox screen or like a drug test to see what kind of drugs he was exactly on that night.
All right, so we get a troponin, it's pending. The tox screen is a very good point. So it was positive for, he was positive for alcohol, and he was also positive for cocaine. So that helps us know what, helps us kind of differentiate what's going on. So, so any other labs you want to get?
Maybe like a blood test.
What blood test?
I'm not really sure.
Okay, so let's go with Dr. Vipa.
Hi, yeah. So maybe a CBC to check for any possible infections from the white blood cell.
Yeah, so his white blood cell count is 6.6, so that's normal. What infections would you be worried about?
Maybe from the alcohol or something.
Okay.
Like
what?
Any effects on the liver?
Okay, yeah. So liver function, we can definitely get. We didn't get it here. Or actually, I didn't write it down. I think it was. I think it was only mildly elevated, so it wasn't really significant. Good. Any other labs you want to get?
Maybe a BMP.
A BMP. Okay. So, and what are you going to be looking for in the BMP?
Maybe something on the kidney, possibly.
Good. And why would we want to know the kidney function?
Just to see how it's functioning.
Yeah. So it's to tell whether or not there's kidney injury, because if there's kidney injury, we might need to do tests that involve contrast, and contrast can be toxic to the kidney, so we wouldn't be able to do those tests. So it's important to know, pretty much for any case, it's always important to know the kidney function. But good job. So Dr. Al-Baldawi, so we got the troponin back, it's 1.2. What do you want to do now?
Hi, can you hear me?
Yeah.
Troponin was 1.2.
I'm sorry?
The troponin was 1.2.
Yeah, it's 1.2.
That's probably, it's a little bit higher than the normal. That would leave me thinking that there might be a heart attack.
Yeah, it's pretty high. So the troponin is high. So what do you want to do next?
Retest it, maybe?
What was that?
Retest this?
That's a very good idea. So we can retest it. We retested it a little bit later. But what's the next thing? So the troponin is high. So let's back up. What does a high troponin mean? What does that tell you?
It's just leading me to thinking that there's a heart attack. There's a problem with his heart somewhere.
Okay, so there's damage to the tissue itself. And so a lot of times that damage is going to be because of ischemia. So you're not getting enough blood flow to the area, and so that portion of the heart is dying. So what's a very fast way to check to see if there's something dangerous going on?
An EKG?
An EKG, exactly. So we get an EKG, and the EKG is shown on the one that I sent you, EKG-A. So do you know what that shows?
I closed it by mistake. Let me open it back up.
It's okay. So while you pull it up, I'm going to answer some questions. So, all right. So the normal troponin is less than 0.04. So it does indicate that there's some type of cardiac injury. The other question I saw. Okay, I think that was. Oh, so do we wait for EKG or immediately administer nitroglycerin? You would definitely wait for the EKG, because if you administer nitroglycerin and it's a right-sided heart attack, you can cause the patient to get worse, and you can actually kill the patient. Because right-sided heart attacks, so heart attacks from the right side of the heart, so the right ventricle that's being affected, depend on the perfusion of blood to the heart to push it forward. And so if you give nitroglycerin and everything dilates and your blood pressure drops, you can't push as much blood to the heart, and so your blood can't push as much blood outwards. And so you can hurt a patient by not waiting for the EKG. So you definitely do want to wait for the EKG.
Sorry to interrupt. I think the EKG is showing a tachycardia.
Let me see. Nope, it looks okay.
Okay.
Which actually, thinking about it, this is not the EKG for the patient. This is just a sample one. And I said the patient was tachycardic. So you are right that the actual patient should be tachycardic, but this one isn't. What else is standing out to you?
I don't. It's not looking too normal to me.
Good. So it's not normal. Okay. So Dr. Haddad, you're saying ST depressions. Can you point out where you're seeing those?
Yeah, in 1 and 2 at the beginning, you can see the depressions.
Yeah. So 1 and 2, and then anywhere else?
Towards the end.
So you can kind of see it in V4, V5. You can also see it in AVF. So the EKG is basically looking at different portions of the heart and seeing, looking at those different leads tells us where that cardiac issue could be happening. So good. Dr. Ayush, you're asking, wouldn't we be apprehensive about the nitroglycerin? So can you explain what you're talking about?
Yeah, sorry. If he's like taken that ED medication like recently, and then we give him nitroglycerin, wouldn't we be risking just like his like blood pressure dropping like really rapidly?
Yeah, so exactly. So we have to make sure that we know when he took his last dose of sildenafil. So I think he had taken it earlier that day, so he did not get nitroglycerin. But yeah, that's okay. A good catch. All right. So so EKG-A shows ST depressions, which Dr. Das, what is that? What does that make you worried about? So we have ST depressions, we have an elevated troponin, we have a guy with chest pain. So what is your working diagnosis at this time? Dr. Antara.
Yes, I was thinking it could be angina because that is usually seen with ST depression and EKG.
It can. It doesn't always have to be, but angina. So to have angina, you can't really have cardiac injury to the point where you're having leakage of troponin. So if the troponin's elevated, it's not going to be angina. So what would it be?
So then like ischemia or something.
Yeah, so it's ischemia. So what's the name of this person's syndrome?
So like a heart attack?
A heart attack. So yeah, so it's like a heart attack. Specifically though, it's a non-ST segment myocardial infarction. And so the difference between an NSTEMI and a STEMI is with a non-ST segment elevation, the EKG is going to have depressions versus actual elevations. But when we look at how the heart muscle itself is injured, the heart is perfused, so the heart gets blood from the outside inwards. So the blood vessels line the outside of the heart, and then they penetrate inwards. And so as the blood is perfusing the heart, the outside is going to get it first, and then the inside is going to get it last. And so if anything is compromising the blood flow, that inside of the heart is going to start to die, and so or have ischemia, and eventually will die. And so as the blood perfusion decreases, there's only a small portion of the heart that is affected, and so you're not having that full thickness death. And because of that, that heart is still able to function, and you will have that depression. The main difference between an NSTEMI and a STEMI is the degree of occlusion of the vessel that's supplying that portion of the heart. So if this is your vessel right here, and you have something occluding it, but there's still a little bit of, I don't know if you can see, a little bit of vessel open, and that can still get some blood flow to the area, but maybe not enough to perfuse the entire thickness of the heart. That's an NSTEMI. But as soon as you close off that vessel completely, and you're not getting any blood flow to the area, and that entire thickness of heart muscle is being affected, you will have a STEMI. And so with the STEMI, you're having a full thickness death of the heart. And so it's important to know the difference, because it's going to change how you manage the patient. And so, so good. So Dr. Damon, how would you treat this patient? What would you do first for him?
For MI. I think you would. Wait, I'm not entirely sure what you would do first.
Okay, that's okay. So, Dr. Liu, James Liu. So you're saying heparin. Why?
Well, for an NSTEMI, we want to prevent a full STEMI. So we want to give him like an anticoagulant, and the one that comes to mind is heparin. So we'd probably start him on a heparin drip, and then we can retake his troponin later to see how he's doing.
Okay, so good. So why aren't we just sending him to the cath lab?
It's not really necessary at this time, right? Because it's not like a full. The full thickness of the heart isn't damaged, so it's not like occluding fully, so it's only partial at this point. So there's no need to send him to the cath lab yet.
But wouldn't he be at a risk of having a full-on heart attack? So why wouldn't we just send him immediately?
That's a good question. I'm not really sure.
It's okay. So yeah. So you're right. We would typically give an anticoagulant, because with the NSTEMI, so the way that NSTEMIs progress from an NSTEMI to a full-on STEMI is if that occlusion forms a thrombus, it forms a clot and completely occludes that area. And so with the NSTEMI, we typically just try to prevent that clot from forming. So you're right, we give heparin. And we usually do it on a drip. And the reason why I do it on a drip versus some other medications like Lovenox, which you can use, is the drip you can turn on and off very quickly. And there's no, within 2 hours, it kind of leaves your system. And so there's not as much of a risk for a bleed. But yeah, good job. So this patient did have an NSTEMI. The chest x-ray, just for the sake of time, the chest x-ray was provided. It was clear, so there's nothing really there. The patient was started on a heparin drip. He received Ativan because the thought was that he was probably having an NSTEMI because of the cocaine. And so in cardiac issues, when you have cardiac issues because of cocaine, you want to decrease the amount that the heart is working. And so Ativan is a benzodiazepine. It's kind of like Xanax. that is going to calm that person down and decrease that sympathetic overload, and will decrease the amount of work that the heart has to do. No nitroglycerin was given because he used sildenafil earlier that day, and then you admit that patient to telemetry, and you go back to your call room. So Natasha is asking, how do you know when to turn off the heparin? It's based. I forget the timing actually. I'd have to look back and see. But typically, what we usually do with an NSTEMI is we send them to the cath lab afterwards when they're stable, and usually there's a lesion that can be stented, and after that stent is placed, you put them on antiplatelet therapy, and that will kind of take care of that whole scenario. But for this patient, he didn't go to cath. He was just put on the heparin for now. Nicole's asking, how did we rule out pneumothorax? So the X-ray was normal, so there was no evidence of a pneumothorax there. But that's a good question. All right, so Dr. Nidhi, at 6:20 in the morning, you're paged because the patient is complaining of a recurrence of chest pain. You go in and you evaluate him, and he's breathing fast and he's clutching his chest, saying like he feels like he's gonna die. What do you want to do next?
So first, I think I would listen to his heart sounds and lung sounds to see if, just in case, like if a lung collapse maybe, then that could be an issue, or just if any sounds are like not normal. And then from there, I would see that and then determine what to do.
Yeah. So it's always good to examine him. You want to do that fast. Yes. But what else are you going to want to do to kind of see what is going on in that patient?
We should probably also look at his blood pressure and pulse to see if anything's different from there as well.
Yeah, so that's good. Vitals are vital, so you want to get those vitals as soon as you can. I actually didn't write them down, so I'm not going to give them to you. Anything else that you can do very quickly to see if this is something that's emergent that you need to take care of?
Yeah, we could probably run another EKG.
Exactly. And so the EKG is given to you on EKG-B. What does that look like?
Okay. It's the changes are more drastic than EKG-A, and since we talked about it being an NSTEMI, would we consider this one could we think that this one would be a full STEMI?
Yeah. So with a STEMI, you have depressions, but with an NSTEMI, you have depressions usually. With the STEMI, wherever those depressions were, they typically will revert and be more elevated. And so if you look at 1, 2, 3, or actually 2, 3, and AVF, those are all elevated now. So he has a full-on MI. He has a full-on heart attack. And so what do you want to do for that patient?
Probably get the cath lab to get a stent.
Exactly. So you want to take them straight to the cath lab. So Dr. Kunduru, if you were to repeat his troponin, what would you expect?
It would probably be really high.
Yeah. So his troponin went from 1.2, and then after we retested, it was 1.1 initially. And then after everything happened, he went from a 1.8, so it's higher than the 1.1 before, and then it went up to 5.8 after that. So it was very, very, very high. So good. So we take him to the coronary we take him for an angio. The angio shows that he has a right coronary artery occlusion, and this was successfully stented, and the patient recovers. Dr. Rothstein, if we did the angio and it didn't show any occlusion of the coronary artery, what would we be thinking of? So if the vessels look completely clean.
I'm not sure, but I would think it's maybe a pulmonary issue.
It can be, but we have a troponin, we have EKG changes, so we know that the heart is something's wrong with the heart. So anything else that can cause something like this.
An aortic dissection, but maybe that's not relevant now. But because I don't know anything about checking for his arms at the moment, but that could cause heart issues.
It can, but what it so just because for the sake of time, with cocaine can actually, there's 3 different ways that cocaine can cause a heart attack. One is what we kind of talked about already, where you have occlusion of the vessel because of a thrombus that forms. Cocaine can make it easier to clot, and so you can have that formation of the thrombus within of the clot inside the coronary artery, cutting off all blood supply. The second we talked about as well is when you have when you're overworking your heart, that sympathetic response is driving your heart to beat really fast, and now you're having the supply and demand not met. So you're having not enough supply to meet the demand of the heart. And the third is coronary vasospasm. So if you have narrowing the heart, so if you go from a heart vessel about that big and you have narrowing, it goes to about that big, you still have blood flow through that area. But if you have vasospasm, if you're looking at the heart from like a longitudinal perspective, vasospasm will cause complete occlusion like that. So there's no blood flow going through that area because it clamps down. And so that's like having a complete clot. And if it happens for a long enough time, you're going to have that same scenario where you're going to have a heart attack because not enough blood flow is going to that area. So cocaine can cause a heart attack like this. And for this patient, it's very likely that he had he had some narrowing before, but now he had full-on occlusion because cocaine probably made it easier for him to clot and cause the heart attack. So yeah, good job. And then lastly, for this patient, he recovers and everything in the hospital. And let's say he goes home, and what is a really big risk for him as far as like sudden cardiac death? Why would he potentially die after having a heart attack in patients like these? Anybody can answer. Yeah, so Dr. Haddad, Dr. Mina, Dr. Ayush, they're all saying VFib. It's an arrhythmia. So when you have a heart attack, it changes the way that your heart is signaling and how the signals are propagated throughout the heart. And so you're more prone to having an arrhythmia like ventricular fibrillation, where the heart muscle itself, instead of beating synchronously, it starts to fibrillate. It starts to not actually squeeze. And as that happens, you're not getting good blood flow because you're not really pushing that blood flow forward. And it's one of the biggest causes of sudden cardiac death after a heart attack. It's the fact that you're not having synchronous beating of the heart, and you're having this arrhythmia that can cause decreased cardiac output. So that's all I have for this case. There's a few more questions, but I probably will post a comment in the stream just to give you a little bit more information. Is there any last minute burning questions that I can answer before I move on to the next group? If not, I hope you guys learned, and I hope this case was interesting to you. It's not, I don't commonly see cocaine, but I have seen it a few times, and I've seen it cause heart attacks. So I thought this case was pretty interesting. Most of the time, it's because of dietary changes, lifestyle, that causes people to have heart attacks. So if there's no more questions, we'll be starting abdominal pain next week. So it'll be a completely new topic, new learning, and I hope you guys had fun. So have a good day and take care and be safe.
Thank you.
Thank you.
No problem.
Thank
And if I didn't call on you guys,
you.
I apologize. We'll try to get you. We'll try to get you in the future sessions.